Welcome to today's web chat on Implantable Cardioverter Defibrillators, or ICDs. Thank you for joining us. My name is Ed Bottomley with the Michigan Medicine Department of Communication. Our goal today is to give you some helpful information with the help of our experts here about ICDs. We'll introduce our panelists in a moment, but first let's go on to a few housekeeping items. So you can submit questions at any time, even now, for our panelists to answer during the Q&A portion of today's chat. Questions can be submitted by commenting on this video, but do note that if you do comment, your profile name or your name will be visible to others participating. If you prefer a more anonymous option, you can also send us a private message via Facebook, and we won't be mentioning anyone's names when we do ask these questions. If you can't stay for the whole chat or want to share the recording with a friend, this video chat is going to remain on our Facebook page, and it will also be posted on the Michigan Medicine YouTube channel soon after that. So now on to our panelists. We have both clinical and patient experts here to answer questions. We have Dr. Ryan Kinane in the middle. On the far side, we have nurse practitioner Laura Horwood, and we're getting a patient perspective from Lisa Mulcrone too. So could you each introduce yourselves just for a quick little background and a little bit on your areas of expertise? Do you want to start off?
Sure. My name is Lisa Mulcrone, and I am a patient. I have had an ICD for almost 12 years. I'm on my second one, and I've pretty much experienced just about all the things that people might want to know about traveling, being shocked, having a pacemaker first, wearing a life vest. So I'm an open book, and I'm happy to share my experiences in the hopes that it can help somebody else.
I appreciate it.
Hi, I'm Laura Horwood. I'm a nurse practitioner at the University of Michigan. I am the clinical lead for the device program. I've been working at the university since 1987 and in electrophysiology since 1992 in pacemaker, defibrillator, and arrhythmia management.
My name is Ryan Kinane. I'm a cardiac electrophysiologist, basically a physician that specializes in heart rhythm disorders at the University of Michigan. I've been here for about 3 years.
Great. Well, let's kick this off with our first question. What is an implantable cardiac defibrillator?
Who wants to go with that?
I can go ahead and take that one.
Right.
Yeah, it'd be helpful if we have an example here. And a cardiac implantable cardioverter defibrillator, or ICD, is a mechanical device, electronic device that is implanted into the chest, so beneath the skin but above the ribs. And it monitors the heart rhythm and rate continuously. And if there is a dangerous heart rhythm that develops, it has the capability of delivering an electrical shock to the heart to reset it back to a normal rhythm.
Okay.
So can I just add one thing?
Yeah, please do.
So this is an implantable device of today. And just to put it in perspective, this was the device in 1992. So just looking back, we've had much technology and improvement in size and, of course, function, but just to show the difference of.
Lisa, is there a difference in weight too? I mean,
I guess there is a difference in weight as well as size. And these were implanted in the abdomen with the leads, either epicardial procedure or leads on the heart or tunneled up into the heart, where this device is much smaller and it can be placed in the pectoral position, which is the general location.
I'll add an additional aspect to this is the more traditional transvenous system, or that has where the wires we refer to them as leads that go through the blood vessel and down to the heart, and they're able to monitor the heart rhythm that way. But more recently, there's also been the development of this type of system, which is called a subcutaneous ICD. And this one of the advantages of this type of system is that the leads do not go inside the blood vessels, and so they're able to monitor the heart without having anything inside the heart or inside the blood vessels at all. And so this device kind of gets implanted on the side of the body, kind of beneath the armpit area, and has a wire that goes this way and up along the breastbone here.
This is the traditional system, but like Dr. Kinane was saying, the leads go actually inside the heart, whereas the subcutaneous device just goes underneath the skin, and the lead is so no leads within the vessels.
Yeah. So there are pluses and minuses of either system, and we can discuss that. One of the advantages of the subcutaneous system is, again, that it's not inside the blood vessels. So if there's any issue with either breakdown or infection or something, which are possible but rare occurrences, it can be removed fairly easily. One of the disadvantages, and I think we'll play on this a little bit and some of the future questions, is that the subcutaneous system is not able to pace the heart or make it beat faster, whereas these, the more traditional, what we call transvenous, or type that lives up here in the chest, are able to both serve as a pacemaker and provide a couple of additional functions.
Which is what I need. So I need the pacing function as well as the ability to deliver a shock, and so that's why I have that type. I would say another thing about talking about how they've changed over the years is the very first one I had lasted 5.5 years, the battery life, and that was actually a little bit beyond what it was projected at. The one I have currently I've already had for 6 years, and projection is maybe another 6 to 8 after that. And so just in a 5.5 year time span, technology jumped so far into advance for the battery life that's a nice benefit for patients to have it replaced less often.
Thank you. That's a good perspective, Lisa. Thank you.
There have been a lot of advantages, a lot of advancements in both battery technology and miniaturization and all kinds of things that each step of the way we're just getting better and better.
Yep.
I guess this would be a good time to talk about the difference, which I think is one of the questions we have between a pacemaker and a defibrillator.
Indeed, that's our next question.
Oh, good. All right. So we already touched on it a little bit, but one of the kind of ways to kind of grossly classify the two types of devices is a pacemaker will correct a slow heartbeat, and a defibrillator will correct a fast heartbeat. So an abnormally fast or too fast heartbeat, and a pacemaker will improve a heartbeat that is too slow. And generally, most defibrillators are also pacemakers, but not all pacemakers are defibrillators. When I say generally, I'm essentially talking about this, the SICD system, which is not a pacemaker. It's the only ICD that does not have any kind of what we call pacing function or ability to make the heart beat.
And in my case, I actually started with a pacemaker for a condition I was born with, complete congenital heart block. So I had a pacemaker implanted. I had not had any major symptoms of passing out or anything like that, but it was a safety measure so that I didn't have a severe case of sudden cardiac death. That would not be good. So I had the pacemaker implanted. And another thing about those is they're incredible little machines because they record the things that go on in your heart. And then the doctors can pull that data off and take a look at what's going on. And what happened with me is one of those regular checkups shortly after I got the pacemaker showed some additional issues of very fast heartbeats.
Ventricular tachycardia.
Yes, ventricular tachycardia. Laura was there actually when that was pulled off, and it was decided that then the pacemaker wasn't enough to protect me from the fast rhythm, so it was replaced with the ICD that does both functions.
Good.
So.
Thank you for that. Our next question that we have coming up, why might a person need one? What conditions would they have where it would be needed?
You want me to go?
Sure, by all means.
There are many reasons, but the most common reason is for patients who have underlying coronary artery disease or have had a heart attack, and their heart is essentially weakened, and they have scar tissue on their heart, and they're at risk for life-threatening arrhythmias. That's one of the main populations that need a defibrillator. They also, people get the defibrillator because they're at risk for life-threatening arrhythmias, or they've already had a life-threatening arrhythmia, and and they survived it, which is a good thing. And then there are many other reasons, which I don't know if you want to expand on that. But
I think essentially we break it down exactly as you outlined, with people who are at risk for dangerous heart rhythm problems, and that can be either because of other issues that are going on with your heart, whether it be from coronary artery disease and heart attacks and scar that's in the heart, or weak heart from other reasons, viruses, inflammatory situations, other indications for or or reasons why your heart would be weak, or people that have had have demonstrated that they've already are prone to having rhythm problems and you are at risk based on that.
And in my case, there's structurally nothing wrong with my heart. And I didn't, I'm not in that risk population of disease and those kinds of things. It's just kind of something that happened during fetal development, most likely. So there are those congenital disorders that can put you at a risk for different heart rhythm things like mine. So, so I try to explain it when I try to explain it to people who know nothing, and I don't know that much about it. But it's plumbing and electrical, and there's nothing wrong with the plumbing in my heart. It's all just the electrical.
Mm-hmm. Yep.
Stuff. Next question: how big is the scar?
That's going to depend on the person and the surgeon
And the device that goes
and the
in.
surgeon.
Yeah.
I will say I know a lot of people, met some great people who have devices, and they range. Some of them you can barely tell. It's a small, thin line. I actually had a reaction to the glue that was used in the last time I had mine replaced, so I developed a much larger scar, and I had to have some scar revision. So, I mean, I'm not afraid to show it. It's not that bad. It goes from about here to here. Mine's a little longer because I had the scar revision, and it's a little wider because I had the reaction, but it's a scar. It's a battle scar.
Right. And the size of the device.
Yes.
With the SICD, and people that have had devices early on, their scars are much bigger. But
Yeah.
the newer devices, I would say, what, 2 or 3 inches?
I'd say probably about that size, and depending on the features and kind of the bells and whistles that the particular type of device that you get implanted will need, the size can vary depending on what it's capable of doing. So, but generally, I would say a scar about that big-ish, and it's generally for the transvenous systems, the more traditional ones. There's a couple of different approaches. You can do kind of a diagonal incision right here, so about that, like that, or some people do more of a horizontal one right around in the same region. Either approach is perfectly valid in terms of getting the device in. The SICD, again, the one that sits on the kind of side of the chest wall, will have 2 scars, generally one about here, just underneath the breast, or some position it more vertical like that, and then a second much smaller incision right at the base of the breastbone that's about 1 inch wide.
And then in my situation, I mean, because they do have to be replaced, they like to go in at the same spot. So, and that's maybe why mine got a little bit bigger, because it's been 3 times now. So.
And the next question, a little bit of a follow-on from that: how much is the ICD going to protrude from my chest?
That kind of depends on, in some ways, your body type. In very, very thin, very small people, it'll project a little bit more. But again, this is the size of the device, so the most that it'll stick out is, about about 1/2 inch or so. And some of the devices are formed a little bit so that they kind of taper off on different sides to allow for a less kind of sharp profile on the case itself. But people that are a little bit larger will be less likely to protrude, but generally for pretty much everybody, you can, if you press on the area, you'll be able to feel it. You wouldn't necessarily always be able to see it in the outline.
Yeah. Mine is a little bit wide. It's a little bit bigger, but a little bit thinner. It's just kind of flattened out a little bit more. Mine protrudes not at all, and that was a decision that my EP and I came to. I said I was concerned about it protruding. I like to think of myself as not that old, and I was still a little vain, and I just didn't want it protruding very much. And so he was able to kind of bury it in the tissue a little bit. So mine protrudes not at all, but you can feel it around a little bit. But it's, sometimes it's just a discussion with your doctor about what's going to work best for you, and his or her ability to place it somewhere that makes sense.
Yeah, there's other,
No, go ahead,
excuse me, other positions that we can put the device. Submuscular, if a person is quite thin and they don't have a lot of subcutaneous tissue and you're worried about erosion or things like that. But just for keeping it in a nice pocket and protected. And some women have opted to do other positions up submammary.
That's kind of basically
Yeah.
where mine is.
Yeah, there are other approach options that we'd certainly be remiss not to mention. There's that we can go beneath the muscle, as you mentioned, the submuscular, and that by putting it deeper tends to make it less prominent. And there's also an approach to, instead of having the incision on the front of the chest, we can go from essentially inside the armpit and kind of hide the incision a little bit down there. Oftentimes, we may involve a plastic surgeon in that type of case, just to help with, we don't oftentimes go in from that approach, so it might be a joint procedure.
Okay.
But certainly many options in terms of if there's a concern about aesthetics, there are ways to deal with that.
Thank you. Next question. What should I expect after surgery? What is the recovery like?
I guess that's me.
Yeah, that sounds good.
It's reasonable. No surgery is fun. For me, so the first time when I first got the pacemaker, and it's the first time the leads were going in, those need to settle a little bit. So the recovery's a little bit longer. And then when I got the actual ICD, a third wire goes in, and that too also needs to stay still for a bit. With both of those two surgeries, I spent one night in the hospital. When I had the replacement, where it was just changing the generator, I went home that same day. And that, it's a little painful like any surgery. I mean, you're still being cut and stitched. And then I would say I took off just a couple weeks of work in all cases. Each time I had the surgery, I only stayed, and I didn't even need to. I could have gone back, but I had sick time. I might as well use it.
Yeah.
So it's pretty easy. There's a little bit of pain. Stay ahead of it if they give you something to manage it. But it wasn't anything that was too hard to overcome. You were given a sling so that you don't raise your arm above your head because you don't want those wires to pull. I wore that mostly when I was sleeping, just to make sure I didn't do it on, because you also don't want to not move your arm completely. But that's really the only thing is not to do that for 6 weeks. Other than that, it's a pretty easy recovery, but go ahead.
Yeah, we've actually
Updated?
we've moved away from that, so we
Really?
don't give
Yeah.
the slings out anymore.
No more slings. So.
Yeah. Not that we're just trying to not give them out. We actually
Yeah.
don't want people to use them. We want people to use their arm more. And so
Great.
it's, and we really, but you kind of hit the nail on the head. What we tell, at least what I generally tell people is to think about their elbow and to not bring it above their shoulder,
Yep.
kind of like this, or back behind the plane of their body. So anything that opens up that, and this is all with the more traditional system that goes up here, anything that opens up the chest like that, that can put tension on the wound or pull, kind of lengthen the where the leads are,
Right.
and that could possibly dislodge them. But otherwise, we want you to use your hands, use your arm.
Right.
If you're putting on a shirt, put on this arm first, and then use the other
Yeah.
arm.
Yeah.
There's a lot of things you can do. I mean, the first day or night, it's hard, but I learned after the first time things to plan for, like bring a shirt that buttons up the front so that you don't have to try and pull something over your head when you're sore or you can't move your arm. Bring shoes that you can slide your feet into if you don't want to bend down. And I mean, there's just things that are more comfortable. Leggings instead of pants that you have to zip up. I took things, second time around, I took things that I'm short. So everything that's up on a shelf that I knew I was going to need in the next couple weeks, I just moved down so that I knew that I could reach things in my house. I cut up fruit and vegetables ahead of time so I didn't have to do a lot of this when I knew I was going to be sore. Ice packs are nice. For women, a strapless bra I found was key. Just because you just don't want anything tugging on an incision. No matter what kind of incision you have anywhere, you don't want anything pulling on it. Mm-hmm. So a strapless bra I wore 24/7 just because it was a lot more comfortable. I learned things after the first time around. So I have a lot of advice for people who are going in to have it that just makes it just easier.
Mm-hmm. That's great advice. Yeah.
Great. The next question that we have, how often does the device need to be replaced?
Well, we kind of touched on that briefly with, as you said, about the improvements in battery technology. But at this point, I think we're I would say on average, it can be varied a little bit between the different manufacturers. There's essentially 4 main manufacturers that we utilize at the University of Michigan. And probably on average about, what do you say, 10 years, you think? Mm-hmm. Somewhere around in that ballpark. And it depends in some ways on how much the device is used. So if the pacemaking aspect of it is used a lot, then that might drain the battery a little bit earlier. And any shocks that are delivered can also drain the battery a little bit. But for the most part, we're getting probably around 10 years, and up to, even some are beyond that, even almost 12, 13 years. So.
Yeah, my projection is that.
Yeah, about that. Yeah.
About that, yeah.
And the newer device, the subcutaneous ICD, the first generation lasted about 5-6 years, and they're projecting 6-ish years for the most recent device. So if you have a subcutaneous device, it's a little bit shorter, just because it's more of its infancy in its technology.
Yep.
Which is really important. I know I'm obviously a grown person, but there are plenty of children who need ICDs. And so when you think about how many times they would have to have that replaced over their lifetime, that's a very long time. So the longer battery lives are really important, especially when you're looking at younger patients. And I know that I had a lot of questions from people when I first got mine. Why are you getting a pacemaker? You're too young. And then when I got the defibrillator, why are you getting that? What, did you have a heart attack? And people don't understand that there are a lot of conditions that you can be born with that require you to have a pacemaker or an ICD right after you're born. And then you have it throughout your life as it is. You need it for your whole life. So longer battery life, smaller devices are really important, especially for young patients.
Yeah, absolutely. Thank you. That's great perspective. Next question, how often should I have my ICD checked?
Well, I can talk about that. Yeah, generally patients will come back to the clinic in 7 to 10 days for a wound check, and we also check the device. The most risk for any issues, like as far as leads that may move slightly or any changes that might need to be made to the device, we like to make sure we check it in 7 to 10 days to catch any of that. As well as taking a look at the incision site, making sure there's no signs of infection. Also at that time, we will set people up for their home monitoring. The device follow-up includes in-clinic visits as well as over-the-phone transmissions. I shouldn't say that's kind of old wording, but home monitoring, it's you don't have to have a landline or anything. In the old days, we used to have a landline, but now it's all sent through cellular transmission or Wi-Fi. So generally, patients will be seen at 7 to 14 days. Then they're seen at 2 months in the clinic because there's, again, Lisa was referring to it, the healing time that it takes for the leads to become kind of secured within the heart. And we can do any final programming changes to save the battery, and any fine-tuning that might need to be done at that time. And then patients can generally go either every 6 months or yearly. A lot of times we will have patients come back to the clinic at the 6th month just because we're introducing the home monitoring. We want to make sure that we're not having any issues as far as the home monitoring goes. The home monitoring includes a little unit that they get to take home, and it sits by their bedside. It will communicate with their device, and it will send us transmissions every 3 months in between their time that they come for clinic, as well as the devices are pretty sophisticated, and they can identify when there's new arrhythmia or there's any device system issues with the leads or the battery itself and the device, and it can alert us to those issues. So at the U of M, we have people monitoring those websites. If there's any alerts that come through, they can respond to that, notify the patient, and then they have regular downloads that come through that we have periodic checks on their device, and then they come in every 6 months to a year, depending on many things, whether they're dependent on the pacing function of the device, how many, are they having a lot of arrhythmias at this time that we're kind of following more closely. But generally patients, if we're stable and doing well, they can come to the clinic once a year with every 3 month home monitoring in the interim.
Yeah, the home monitoring is pretty amazing. I mean, people are pretty shocked because you literally only have to walk into the room where the monitoring system is, and it just wirelessly pulls it. You don't have to hold anything up to your chest. You don't have to, the new ones. You just literally walk in the room, and then it magically sends it off to your doctor's office. And then they'll call you if they see anything that's concerning, but in most cases I don't ever hear from them, and everything is fine. But Laura mentioned the alert that will happen, and I had that happen to me with the first device. they beep if your battery gets low, or if the charge time, the amount of time it takes for the device to charge up to deliver a shock, gets too wide. You will get an alert. And mine beeped, and it was very strange. I was sitting by myself reading a book, and I heard this like muffled beeping sound. It sounded like a truck backing up that would be like in my backyard, and the windows were closed. So I went to turn my head, and I went like that, and then I went, nope, that is definitely coming from inside of my chest. So yeah, and they give you plenty of time. I mean, there's like a 3-month time span that you would get that alert before you would actually need to have it replaced. So, and then it beeps at the same time. For mine did. It beeped, the settings where it beeped at 8:30 in the morning and 8:30 at night, 16 times it would beep. So we used to laugh in my office because we had an 8:30 stand-up meeting every morning. So once it beeped, that was like I was the entertainment for the day. It was like, shh, everyone listen to Lisa beep until I could get in and have them turn off that beeping function until I could get it replaced. But you know, they are very sophisticated machines.
Yeah. Some of them buzz too. They give you a little vibration.
Another company vibrates. And we like to demonstrate that in the clinic when we're seeing the patient for the first time for the wound check. That we'll let them know now. It's important to you that you know that this could happen.
Sure.
They also can beep and or vibrate if the device is trying to send an alert through the home monitoring, but you're not near your home monitor, and it will alert you that that you need to call. So we always tell our patients that if you hear beeping or feel a vibration from your device, then that's the device telling you we want you to call the clinic. And it is, again, it's a backup. If you're traveling and you didn't take your home monitor with you, then that's kind of a backup to the home monitoring.
Yeah. And that generally, if we're sticking to the follow-up schedule, the beep or the buzz will not be the first indication that the battery is running low. We'll know that well ahead of time.
Yeah.
And so that's we're not dependent on that either.
Right. And my appointments got a little closer together as my battery life went down too, just so that people were making sure. And my home monitoring reports were going in more frequently as the device got to the end of its life.
Mm-hmm. One thing to mention when we're talking about the follow-up visits is that we are able to, as Laura mentioned, make some adjustments and fine-tuning to the device at that time. And that does not involve any kind of incision or any opening of the device. It's all done essentially with kind of like Bluetooth type technology. We can just put a little device over where the system sits inside the body, and we can communicate with it and change the programming, do all kinds of things. So.
Mm-hmm. And the home monitoring is also very important. I was shocked once. And so all I had to do was send a report in immediately. I didn't have to. I live in Lansing. My doctor's in Ann Arbor. I didn't have to go anywhere. I could immediately send a transmission, and they could see exactly what had happened.
Yeah, when patients call us and they tell us they have symptoms or they had a shock, we actually ask them to send a transmission because we want to verify, was the shock appropriate or not? Is there other things going on with the patient? What are their symptoms at the time? And then we direct them appropriately, whether to the emergency room, it looks like we might need to see you in clinic, or, this is kind of your, it's stable for where you're at, so.
And we have a few questions on shock coming up in a second
okay.
as well, so we'll delve a little bit deeper there.
Okay.
The next question, does the ICD protect me from a heart attack?
I guess I can
let
talk
you
about
get
that one. That can be a tricky question because not based on anything medical, but more based on definitions. And so a heart attack in the medical community is often when we talk about a heart attack, we're talking about a blood clot in one of the arteries that feeds the muscle of your heart, so a coronary artery, and that basically starves that portion of the heart muscle of blood, and you get pain, and if that blood flow isn't restored, it can turn into scar and cause problems. So that's a heart attack. And that is all, as Lisa mentioned, a plumbing issue. That's something where you get a clog in your plumbing and you're not having any flow, and the heart muscle gets upset about that. And that can sometimes then result in a rhythm problem. But in and of itself, you can have a heart attack without having any heart rhythm problems. So the defibrillator will not prevent a heart attack from happening, meaning stoppage of blood flow in the coronary arteries. That's all done with medications primarily, and sometimes stents, things along that nature. But if that heart attack results in a rhythm disorder, the two main ones we worry about are one called ventricular tachycardia, one called ventricular fibrillation, then the defibrillator can certainly address those things. Now, taking a step back, outside of the medical community, oftentimes anybody who dies suddenly will be classified as having a heart attack or having an issue with their heart and dying suddenly. So that could be either a true heart attack or a sudden onset of a rhythm problem. And so it really comes down to what we're talking about and what the defibrillator can deal with. It can certainly deal with rhythm problems, but not necessarily those plumbing blockage problems.
Okay. And our next question involves an emergency plan. Why do I need an emergency plan?
Well,
go ahead.
As far as the device goes, it's always good to kind of have an idea what to do in case this happens. So what do I do? Patients often will ask, if I get a shock, what do I do? Do I need to go to the emergency room? And not necessarily. We usually tell patients that, if you do receive a shock, because sometimes patients get symptoms prior to a shock and then they feel good after it. Sometimes patients get therapy from their device and they don't feel well, they feel lightheaded, or they could get another therapy. So it's always good to know what to do in case. If people are if they got a shock for the first time and they felt okay, they didn't have any symptoms, we always instruct our patients to call and send a transmission so we can see what it is and appropriately, triage them and tell them, what they need to do or what's going on. If they pass out, it's always good to know, and at least also tell your family members what to do. So if you're passing out prior to the device treating you, that, there's many reasons why you would maybe want to seek care, because you could be on blood thinners. Did you hit your head? Did you get hurt? Are you having more arrhythmias and things like that? But it is always important to know what to do, because life happens and we never know. And that's one of the problems with arrhythmias. It's really unpredictable. We don't really know if and or when something would occur. So it's always good to be prepared. Also, people travel and they go to other areas and they say, well, what if something happens while I'm traveling? So it's always good to have a plan. And then Murphy's Law usually occurs. If you're ready and you have a plan, then you're usually in good shape.
Fortune favors those
the
who are
moment
prepared.
you were saying that, Murphy's Law jumped into
Did it?
Yeah, and another thing to think about is the defibrillator can be thought of almost like a fire extinguisher. It's there to help as a last kind of fallback option. But if you get a shock, that doesn't mean it doesn't mean you're done and in the clear necessarily. Sometimes it does, but oftentimes we want to know. We want to prevent those shocks from happening. You want to have people who are at risk for needing or for developing heart rhythm problems and needing a shock. We want them to have the device as a failsafe, but ultimately we want to do other things for that person to prevent those shocks from ever happening. And so having a plan to follow up on any kind of delivery from the device, whether it be a shock or whatever, is important, because it may mean that things need to be tweaked, changed, adjusted, and you're not necessarily, in the clear at that point afterwards. So.
Okay, well, we touched on the shock a few questions ago. This is a question for you, Lisa.
Mm-hmm.
What does a shock feel like? I think you already answered the next one. How many times have you been shocked?
I have only been shocked once. I think in talking with other patients who have defibrillators, I think there's a wide range of what it feels like. And some of that is just based on how many joules of energy you get shocked with. In my instance, it wasn't a huge amount. It only took one shock. It only took one try before my rhythm was restored back to normal. But the best way that I can describe it is it hurts. I will say that. There's no getting around that, but it's worth it because your life is saved. It felt to me like somebody swung a bat at right between my shoulder blades and my chest at the same time, over in an instant, not even an instant. And the way, for me, what happened is there was nothing that told me I was going to get shocked. I wasn't doing anything. I wasn't exercising. I wasn't scared. There was no adrenaline. It wasn't any of those things. And in my particular case, there is no way to determine why I go into these rhythms. I just do. So there's nothing I can do to prevent it. They've happened in my sleep. So it's not like there's anything I can do. But the time I got shocked, I just felt things kind of closing in, and then I felt like I got hit. There was kind of like a little bit of a flash, and then everything was fine. It was clear. There's no lingering pain. I was a little shaky, but it might have just been because I was thinking, oh, I think I just got shocked, and that in itself will make you kind of get a little shaky.
Yeah.
But it literally is over in an instant. I mean, my whole thing from the time that my heart rate was at 358 to the time I got shocked to the time I felt fine was 40 seconds. So very fast, and like I said, no lingering pain after. But it hurts. It definitely does. I know some people say it's like getting kicked by a horse. I don't think it felt that much pain, but then again, I may have had a less intense shock.
Yeah.
It's really perspective,
Yep.
too. Everybody experiences pain different.
Mm-hmm.
So one person may feel like, oh, that was really hard, and be startled, and people can react differently.
Yeah.
So I mean, it's just what people report. Some people say it took me to my knees, and I have other people that say, you know what, it really wasn't that bad. So you've got a wide range of the way people perceive the episode, and some people may have a little kind of a brief warning, maybe, or that things were closing in, or people may feel some palpitation, or a brief lightheadedness, and then that may just resolve, because the really important thing to point out is technology and how we program the devices now. We always program pacing therapy first, which is a painless way to convert an arrhythmia, and we always program that on first, and we give actually a few tries of that before going to shock. Shock is really, like Dr. Kunin was saying, the last resort. We want to convert rhythms if they're amenable or they can be pace terminated. We want to do that first, and so many times people will get that and not even know it.
Yeah.
Right.
But if and when they do have to have a shock, you will get many different perspectives. And the consensus generally is that it is quick and it's there and it's gone. There's not a lot of lingering pain or discomfort, but some patients have reported to me that their chest was sore after. So you get a little bit of variation depending on the person.
Yeah. And in my case, for me, I wasn't even sure that's what it was because it was the first time, but I thought, well, that must have been a shock, and it had to have been. I don't know what else, like no one hit me. But you don't, it's not like you have a bruise. If I had actually gotten hit by a baseball bat, you'd have a horrible, painful, lump the next day. But, and in my case, it was absolutely appropriate. It was an appropriate shock. Sometimes inappropriate shocks happen. Mine was incredibly needed. You've probably seen my tape. And I think my EP at the time said, even though you were in a hospital, arrhythmias are so sudden and they can result in sudden death so quickly that even standing in a hospital without my device, it was a very slim chance that I would have walked out of that hospital. So I'll take the baseball bat to the...
It's also not...
Those statistics are good. The 5% survival for out-of-hospital cardiac arrest, whereas with the defibrillator, their success is 98, 99%.
I mean, I went to work the next day. I mean, if I hadn't had the defibrillator, I probably wouldn't have lived. And with the defibrillator, I went to work the next day like nothing had happened.
That's great. One thing I said today about the shock that some people have asked me is it's not going to blow you across the room, which like it's not a movie, it's not the the big dramatic boom kind of thing. It is a big dramatic boom, I imagine. It's happening inside of you, but it's not a big electrical jolt that's going to make you go flying across the room. So
yeah. It is, but and I think an important thing to remember is that was the physical part, was the easy part, and mentally, that's where your head gets into it a little bit more. Luckily, I have great friends who had been through it before, who I've met through Laura and some of her colleagues who connected us up, and I got online right away and started emailing them saying, hey, you guys, I think I got my first shock, and I got some great advice from my friend Erica, who said, you're going to be fine, but be careful because a couple days down the road, it might hit you more emotionally. And that is exactly what happened. I went to it was 3 days later, I was shopping at Meijer, I got in line, and I've never had a panic attack in my life. And that's the best way I can describe it, is I felt like, oh my gosh, I'm going to get shocked again. And it was ridiculous because there was none of the same symptoms that I was having then were anything that I had when I got shocked. But my head was I was getting in my head, and I just started to panic. And luckily, I could think back to what Erica had told me, and I thought, okay, this is normal. This is what she said was going to happen. I did leave my groceries and went home, but it just takes a little bit of time. And I went, and I had talked to a counselor through our employee assistance program when I got the defibrillator, because it's a lot to handle. It's a lot to handle. I had a much harder time emotionally than I did physically, both in getting it and in getting the shock itself. So it's just really important for people to know that's normal. Everybody processes things differently. There's no one right way to be a patient with a defibrillator. And there's no one right way to recover or recover emotionally. It's just really important that you talk to people, talk to your doctor, talk to your nurses, talk to support systems, your family, and reach out and make sure that you get the help that you need to get whatever you need to get you through that health crisis. Because it's you get angry. You're angry at your body for betraying you. And you need to work through that before you can kind of get on with the rest of your life. And I always like what my EP said. He said, I put this in you to live, so go live. And that's a really important thing to remember.
Yeah. That's fantastic. Now, talking of support systems and family, our next question, what should my loved ones expect once I get shocked? Do they need to do anything to help?
For me, and I take my loved ones and my coworkers, I spend a lot of time at work, and they were kind of concerned, like, well, what do we do? Do we call the ambulance? No, I'm fine. The one thing I just tell my family is to, there's nothing, if they're touching me, they're not going to get shocked. That's important. But I did not pass out. I didn't fall down. I didn't pass out before my shock. I didn't pass out when I got the shock. I didn't fall down. I just remained standing. It felt for a minute like something went away, but I didn't go down. But people do. So I think it's important that people are in a safe place so that they're not going to fall and hit their head or do something like that if you're about to get shocked. So that's what I tell my coworkers. If I just say, if I say help, or if I say I'm going to pass out, just make sure that you're behind me or something, just in case I fall. And then it depends on what happens after. This is in me to save me, so there's really nothing anyone needs to do if I get shocked. It's like you have a little paramedic with you. And so I tell them, no, don't call an ambulance unless I start getting repeatedly shocked and it doesn't stop. But with one shock, and if I'm feeling okay, that's what it's there for.
Right.
That's generally what we tell people,
that's exactly what we tell people. We don't want people running into the emergency room unnecessarily, but it is why we like them to call and let us know, and we have them send a transmission so we can confirm it. Because devices are man-made, and they can go off for the wrong reason, or if there is some issue, we like to know that earlier than later. And so if there was an issue or you got shocked for the wrong reason and we needed to direct you to the emergency room, we would want to do that. So, and at University of Michigan, we do have it so that you can call Monday through Friday, or 7 days a week, right? 24 hours, because we do have people on call that if there was an issue, they can check the home monitor and direct you appropriately.
In my particular instance, I was in the hospital,
Yeah.
and so the nurse of my coworker who I was visiting in the hospital said, "I'm taking you to the ER. I don't care." And I said, well, I don't know that I really need to go, but she was insistent. So she said, especially if it's your first shock, you might as well go, make sure everything's okay. So that's where I ended up. But
I definitely think that's a reasonable approach on the
Yeah.
first shock to call.
Absolutely.
I mean, if you
Yeah.
feel fine, call. If you don't feel fine, just go to the emergency room
Yeah.
directly
Yeah.
right away.
Next question, this is also for you, Lisa. How has the ICD changed the quality of your life?
I don't think it really has. I mean, like I said, my doctor said, go live, so I've done that. I work a full-time job. I've done a ton of travel. I exercise, I run, I bike, I kayak, and I think the thing that's really important to remember is it's not the fact that you have an ICD, but what's the underlying condition that requires you to have the ICD? Because there's a wide range of things. So if you have, major heart issues and that's why you have it, and you're not supposed to exercise or you're not supposed to do X, Y, or Z or take a certain medication, that's because of the condition, not the ICD itself.
Okay. Yeah.
For me, I don't have any, I don't take medications, it's not adrenaline based, there's nothing that anyone can really prove that causes me to go into the tachycardia, so I just live my life. I've done a whole bunch of travel. I did a round the world trip with my coworkers where I work at Michigan State University, but we traveled around the world documenting work that we were doing around the world, and so I went to 11 different countries in a 7-week time span. So we were constantly in and out of planes and going through security. I know people have a lot of questions about security. You just say you have a pacemaker. That was easier than saying an ICD, especially in a lot of the countries we were in. And every country understood. They were like, okay, all right, great, come over here, we'll pat you down. And it was no problem. And I was in really remote places. We were in a couple places in China, and we were in Mexico, Brazil, Costa Rica, Malawi, Zambia, Rwanda, Bangladesh. We were way out in the bush in some of those places, very far away from places. But I didn't let that stop me. I mean, I had the defibrillator. That was what was going to save me. So I think that's a really important thing to remember. It shouldn't take away the quality of life that you have. You have to make adjustments. It changes it. It's a new reality. You have surgeries, you have device checks, you have, to go around security sometimes. There's little things like that, but you shouldn't let it ruin your quality of life. Like I said, the emotional part was the bigger part to get over. Once you get past that and say, it's okay, yes, this can deliver a shock, but it's there to save my life. But it takes some time to get to that understanding and to make peace with it.
There's definitely a normal adjustment period for all patients, and Lisa, I think, is remarkable. She's done very, very well. And some people may or may not have as good of coping skills early on, so sometimes some people may have more difficulty early on with adjustment, but I think it's important to know that a certain number, up to 40% of people, do experience anxiety, depression, and with any life change or something significant in your life, there is an adjustment, and those can be normal situational things that occur.
Yeah.
So we want to point out that it's important to recognize that can occur. If family members or you find yourself, not wanting to go, you're withdrawing, this isn't why I got a defibrillator. I got it to protect me so I can continue to live. That you need to seek help, ask for help. Get counseling, join support groups, ask your physicians, your nurses can I talk to other people? And we do have peer support at U of M. And Lisa is a wonderful peer support person, and as many other patients have been.
Well, you say that I'm great, but there was a period where I was not great, and I am not afraid to admit that. When I first found out I had to get the defibrillator, Laura was actually there, and she can attest. I completely lost it. I broke down, and she was worried. She was wondering if she needed to drive me home because I couldn't believe that I needed it, and I just couldn't process it. And then after I got it, apparently, when I woke up out of my anesthesia, I was very angry. So I've been told. so angry that I believe Psych Consult showed up at my bed later that night, just to make sure that I was processing things okay. But that's okay.
It is.
That happens, and I was pretty depressed for a couple of weeks after, maybe even longer, maybe a couple of months or so, where I did need to go talk to a counselor and talk through it and get through it and talk to other people who had it. But what I found is through the years, it actually helps me to help other people. It helps if I can put a perspective that they need when they're facing it that maybe I didn't get from somebody right away. Then I'm willing to do that. I'll talk to patients. We've done a lot of other work.
Oh, yeah.
We wrote a book.
We did a couple books. Lisa, I think you have 2 stories, right?
I do. I have one in each
you have
book.
one in each. So these are really nice books that they're a collection of patients' stories. That you also hear from psychologists in these books, and they provide a lot of different resources. These are something that we put together at the University of Michigan with our patients, and they are free for download on open.umich.edu, as well as available on Amazon. So, and all of the proceeds that we get from the purchase goes to restocking them and we give them free to our patients. But it's nice. This is an important thing because people realize that they're not alone.
Yep.
And oh, yep, I felt that, and oh, yep, that happened to me, and oh, that's nice to know, and oh, this person, they tell about their story, their challenges, and things that helped and things that didn't help, and things that maybe they're still working on, and life is kind of an ongoing thing. So it's nice, and we have this second book is just women in the front and men in the back. So we also found that women have women issues, and men, can get together and talk about their issues. And then, of course, we have our family members. So you have your spouse or your sibling or your parents. So any significant event for a person affects the whole family. So.
Thank you for that, Laura. That's
welcome.
fantastic examples. Next question, am I able to drive a car? What if I have been shocked? Do I have to wait to drive?
I think that in the state of Michigan, if you pass out, then by law you're not allowed to drive for 6 months. And I think the recommendation is similar for ICD shock. And it may be slightly different for people who carry a commercial driver's license. But from a physical standpoint, physically you can drive the car, but whether or not that's a good idea or lawful is a different consideration. So.
The Michigan regulation is if you pass out, lose consciousness for whatever reason, arrhythmia, diabetes,
Anything,
seizure, and there's no mandatory reporting, but you would be liable if you got into an accident again. So they request no driving for 6 months. With patients, because they get a defibrillator, and they've never had a passing out, so just because you have a device doesn't mean you can't drive.
Right.
Okay.
So that's an important thing to point out. It is also important to point out that every state, their regulation is different. So like Florida, it's a year. Other states, it's a different amount of time. So that's important to point out, as well as the whole, with ICD shock, it may just depend on your provider, but when I talk to patients, I think if they've had an arrhythmia, but they haven't passed out, and then by law, you can still drive.
Right. There's nothing in the law specific to shock.
However, when it's really fast or it occurred during sleep, and from a judgment standpoint, from a medical judgment standpoint, you may say, you probably really would have passed out with this arrhythmia. And there's, we don't know if you passed out because you were sleeping, but we may recommend that, it's not a good idea to drive right now because you had this episode in this fast rhythm and you likely would have lost consciousness.
Okay.
It's very rare, actually, that people do lose consciousness prior to a device therapy, just because the device is very quick to act. It delivers pacing therapy quickly, and generally that will take care of it. So it's pretty uncommon with the defibrillator that you will pass out.
And thank you for that. Looks like we have about 5 or 6 minutes left. We happily have still a few questions to answer, so we'll try and get through them. The next one, can I get an MRI?
I'll defer to our resident MRI expert.
Okay. Yes, you can get an MRI. There's a lot of literature about MRI and ICDs. A lot of the devices now are considered MRI conditional. MRI conditional means they're not safe and they're not unsafe. So people can undergo an MRI as long as precautions are taken. So it requires us to program them because if they went into an MRI without any programming, the device could fire or it could stop pacing if they relied on pacing. So we actually we have a process at the U of M that we will check the device, make sure it's functioning properly, and then a nurse will accompany the patient to the MRI, do the appropriate programming changes depending on what they need for them, for their condition, monitor them while they're in there, and then reprogram and make sure their settings are appropriate when they leave. They're monitored because the defibrillator has to be deactivated for that period of time. So it would, when you have risk for an arrhythmia that requires, life-saving therapy, we don't turn them off and not monitor the patient. So, and also at the U of M, we do devices that are non-conditional. So devices that weren't necessarily approved by the FDA, but with precautions, again, we can safely put them in for an MRI. And monitor them, same process.
Okay. Long story short, probably.
Yes. Yeah, probably. Sorry, long story short.
So we have
And I think that's important too to point out that technology and protocols are constantly changing. So if you were to Google, "Can I have an MRI?" you would find a lot of places that say no.
Yeah.
But there are places like the U of M have developed a new protocol to make that happen. So a lot of it's going to depend on your provider, where you are, your particular condition, those kinds of things. But so I think it's important that you always check with your provider for the latest information because things change so rapidly. I think it feels like to me in this field. A patient that I spoke with just recently who found out she had to get one was worried she couldn't use her microwave. That is such old, way back when they used to put up signs that said microwave in use so that people with pacemakers wouldn't go through. That's completely changed. I use my microwave all the time, so.
And you know what, that's fantastic because that moves perfectly onto our next question,
good.
which is, this is a Facebook question for you, Lisa. Do you have to be careful around any electronics or any other devices because of your ICD? And examples, airport security scanner, smartphone Fitbit, metal detectors in a store, radios, jumper cables. What are the risks that you know of, if any?
It's a lot of it is just caution of distance. So I use my cell phone probably more than I should. So but you don't want to put your cell phone right up against your device. But talking on the phone, it's not really going to do anything. I wear an Apple Watch.
6 inches for the phone.
6 inches. It's store security, they're not strong enough to deactivate your credit card, so they're not going to deactivate your thing, but you don't want to linger through them, so just go through. So especially in, Christmas crowds, I push my way through. Excuse me. Airport security, those are a little bit stronger. I know some people who go through them. I choose not to. It's really easy now with the X-ray ones, the ones where you do that, and I think because those aren't magnetic, so those are fine. So any airport that's got that, that's great. If they don't, and I went through a lot that didn't, I chose to get a pat down instead of going through the airport security, and that's that's a personal choice. Some people, like I said, who have ICDs, just say, well, I'll just go through it quickly, it'll be fine. Especially because I was going in all these really remote places around the world, I thought, you know what, I think I'll just take the pat down. But as far as I'm trying to think of other things.
The main ones we tell people are arc welding can be an issue.
I don't do a lot of arc welding, so I don't need to worry about that.
So things that generate high energy electrical fields, arc welding, leaning directly over a running alternator in a car, big electrical transformers, and is it partly depends on your underlying condition too. So if you are dependent on your pacemaker, those are a little more concerning than if you're not, and whether or not it's a defibrillator versus a pacemaker. So, but all of these things, the manufacturers are well aware of the issues that that can affect the device. For the most part, kind of general, household type appliances are for the most part fine. But if you have a specific question, you can always contact the companies. They're very forthcoming with that information. They'll work with you directly on what you specifically question you have on that.
It's important. I think that's a really important piece
Yeah,
of
it
information.
is, and it's always about proximity. You just always, arm's distance
Yeah,
away
that's usually fine.
is
Right,
usually
just depends on-
a good rule of thumb.
Yeah, I have a weird one where I work because I work at the university and at Michigan State, and we have a cyclotron, and that cyclotrons are mega magnets. So I literally can't even go in the building. So
Interesting.
because it's so magnetic in the building that if you hold up a line of paper clips, it will stretch out. Yeah, it's very magnetic. So whenever we have work that needs to be done over there, and I work in public relations, I can't cover those stories. I can't go to the cyclotron. So
Right.
I'm okay with that.
Yeah.
Yeah.
I'm not really into nuclear physics.
Right.
And you know what? It looks like we've run out of time. But thank you all for your expertise. Thank you for these answers. I think they've been very, very useful for our audience. This is going to be up on our Facebook page. So if you just tuned in, you can always rewind to the beginning to look for other questions. And we'll also have it up on the YouTube channel for Michigan Medicine as well. So thank you all very much.
Thank you.
Thank
Thank
you
you.
for your
Thank you.
expertise. Thank you to our audience too.